If you or someone you love is over 65, the next time you check into a hospital, someone is going to hand you a clipboard and ask you to sign a few routine forms. Before you sign a single one, watch this. Hospitals across the United States are quietly using legal gray areas to turn ordinary senior admissions into financial traps. Traps that can cost you thousands of dollars out of pocket, or worse, cost you the rehab care you need to recover. Today, I'm walking you through 5 of the most common traps seniors fall into inside American hospitals. And more importantly, the exact words you need to say to protect your health and your savings. I'm Dr. Revealio. I focus on cardiovascular health and healthy aging, and over the years, one pattern keeps showing up in the families I work with. It isn't that hospitals are staffed with bad people. It's that the system surrounding good people is quietly built in a way that costs seniors money, and sometimes costs them their recovery. What I'm about to share isn't rare or exaggerated. It happens every day, to careful, intelligent people who simply were never told the right questions to ask. By the end of this video, you will know exactly what to say and exactly when to say it. Trap 5. The out-of-network doctor hiding inside an in-network hospital. Picture this. A senior does everything right. She checks that the hospital is in-network with her Medicare Advantage plan, confirms it over the phone, and walks in feeling secure. 3 weeks later, an envelope shows up with a bill for over $1,000 from a doctor she's never heard of. The hospital was in-network, but the anesthesiologist who walked into her procedure, or the radiologist who read her scan, or the ER doctor who saw her at intake, had their own separate contract, and it wasn't in-network at all. Because that one detail was never disclosed, the bill becomes hers. This is known as the out-of-network specialist surprise, and it has quietly affected Medicare Advantage and commercial insurance patients for years. The building is covered. The doctors working inside it may not be, and almost nobody tells you that at check-in. Here's what's changed. The Federal No Surprises Act was passed specifically to close this gap, and it gives you a right almost nobody exercises, because almost nobody knows it exists. The moment you or a loved one arrives at any hospital before any procedure and before any specialist walks in, you have the right to say this to the staff or the billing office. I only consent to treatment by in-network providers, under the No Surprises Act. Write that sentence down right now. Save it in your phone. That single sentence puts the hospital on formal notice. If an out-of-network specialist is brought in after you've said it, the financial responsibility shifts back to the hospital, not to you. I'd genuinely like to know, has your family ever received a confusing medical bill weeks after a hospital stay from a name you don't even recognize? Tell me what happened in the comments. Someone else watching right now is dealing with the exact same thing and hasn't found the words for it yet. Trap 4. Being discharged before you're actually ready. This trap doesn't involve paperwork at all. It involves a rushed conversation at the moment you're most vulnerable. Hospitals face real financial pressure from insurers to free up beds quickly. And sometimes that pressure shows up as a discharge that happens before a senior is truly ready. A doctor walks in and says, "You're doing well enough to go home." Because a doctor said it, most people simply get dressed and leave. 3 days later, they fall getting out of the shower, or a wound isn't healing properly, and they're back in the emergency room, a trip that often costs far more than the extra days in the hospital would have. This pattern is sometimes called premature discharge, and here's the part almost nobody knows. Medicare patients have a legal right to appeal a discharge they believe is too early. That right exists today, and most seniors have never heard of it. If a hospital tells you it's time to go, and you or your family don't feel ready, you can request an expedited appeal through your local Quality Improvement Organization, or QIO. You can find yours at medicare.gov. Once that appeal is filed, the hospital legally cannot discharge you while it's under review. The words to use with your care team are simple. I don't feel medically ready for discharge, and I'm requesting an expedited appeal through the QIO. Consider a retired school teacher recovering from hip replacement surgery. On day 2, after a brief physical therapy evaluation, her doctor suggested she go home the next morning. Her daughter, who'd learned about this exact right, calmly asked the nurse whether they could speak with the case manager about a QIO appeal. The tone in the room changed immediately. The discharge was delayed, and her mother spent 2 more days completing her physical therapy baseline before going home safely. Knowing 5 words made the difference. Trap 3. The silent medication swap. When a senior is admitted, the hospital pharmacy works from its own approved list of medications, called a formulary. The blood pressure, heart, or thyroid medications that have been carefully calibrated for a patient over months or years may not be on that list. So, the hospital substitutes a different brand or generic, often without clearly telling the patient or even the admitting doctor. For adults over 60, a sudden medication swap isn't a minor inconvenience. The cardiovascular system is especially sensitive to these changes, and the results can include dizziness, blood pressure swings, or irregular heart rhythm. On top of the health risk, hospitals frequently charge premium rates for the substituted drug, so the patient ends up paying more for something that may not even be the right medication for them. The fix here is something you can prepare before you ever need it. Keep an updated written list of every medication you take with the exact brand name, dosage, and timing. Bring it with you to every admission and hand it to the admitting doctor with these words: "Please do not substitute or alter any of my maintenance medications without an explicit clinical review and my written consent." That sentence shifts the responsibility to the clinical team. They must flag any substitution to you before it happens, not after. If you've made it this far, stay with me, because trap number 2 is the one that financially blindsides more seniors than anything else on this list. And most people sign away their protection from it in the first 10 minutes of being in the building, while they're frightened, in pain, and holding a clipboard. Trap 2, the blanket financial responsibility form. Walk into almost any hospital in America for an admission, and within minutes, you're handed a stack of forms, consent forms, privacy forms, insurance authorizations. Buried somewhere in that stack, sometimes on its own page, is a clause stating that you assume all financial responsibility for any service not covered by insurance. Most people sign without reading it carefully, because they're worried, in pain, and someone is waiting for the clipboard back. That signature can give the hospital the legal footing to bypass standard insurance negotiations and bill you directly at full inflated rates for anything Medicare or your insurer doesn't cover in full. This is called balance billing, and it can mean thousands of dollars in charges your insurer would otherwise have negotiated down, except you've already signed that protection away. Here's what to do instead. Before signing any financial agreement, write this phrase directly next to your signature, not instead of signing, but alongside it. Signing only for authorized insurance benefits, not personal financial liability for uncovered balance billing. Write it in pen, right in front of the intake staff. It's legal, it documents your intent, and it protects that signature from being used against you later. If someone in your life is over 60 and has a procedure coming up, take a photo of that sentence right now and send it to them. Trap 1. The observation status trap. According to CMS data, roughly 3 out of every 10 Medicare patients admitted to a hospital each year are placed under something called observation status. Hundreds of thousands of seniors annually. Under this classification, a patient is technically considered an outpatient, even while lying in a hospital bed, receiving specialist care, eating hospital meals, and being monitored around the clock. Here's why that classification matters so much. Medicare Part A, which covers skilled nursing and rehabilitation care after a hospital stay, only kicks in after a formal inpatient admission of at least 3 consecutive days. Observation status doesn't count toward that 3-day minimum, not 1 hour of it. That means a senior can spend 4 nights in a hospital bed, need rehabilitation afterward, and receive a bill for the entire rehab stay out of pocket, sometimes tens of thousands of dollars, because on paper, Medicare never classified them as admitted. Consider a retired tradesman who came in with chest pain and fluid around his lungs. He spent 4 nights in the hospital with a full care team and a specialist, fully believing he'd been admitted. When his wife called about rehab coverage after discharge, they learned he'd been under observation status the entire stay, and Medicare Part A didn't apply. The rehabilitation bill came to over $20,000. Nobody had ever said those words to him. Here's what you now know to ask. The moment you or a loved one is placed in a hospital bed, ask the attending physician or case manager directly, am I admitted as an inpatient, or am I under observation status? If the answer is observation status, say this: I'm requesting that my status be reviewed for formal inpatient admission based on medical necessity. That request must be documented, and the care team has to respond to it. In many cases, when a patient or family member explicitly asks, the status is reviewed and changed. Hospitals are also required to notify Medicare patients of observation status in writing through what's called a MOON notice, the Medicare Outpatient Observation Notice. If you haven't received that notice within 36 hours of arrival, ask for it by name. Have I received my MOON notice? Those 5 words tell the hospital you know your rights. Your 5-sentence hospital protection plan. Before you go to bed tonight, take out your phone or a piece of paper and write down these 5 phrases. 1. Am I admitted as an inpatient or under observation status? 2. I request my status be reviewed for inpatient admission based on medical necessity. 3. I only consent to treatment by in-network providers under the No Surprises Act. 4. Please do not substitute my maintenance medications without clinical review and my consent. 5. Signing only for authorized insurance benefits, not personal financial liability for balance billing. 5 sentences. That's your entire hospital protection plan. Keep it somewhere you can find quickly and commit to carrying it with you for the next 30 days. To every appointment, every specialist visit, every hospital admission for yourself or someone you love. In 30 days, it becomes a habit you don't even have to think about. And the people who build that habit are the ones who walk out of hospitals with their retirement savings intact and their recovery protected. In our next video, we're covering what happens after the hospital when you're sent to a rehabilitation or skilled nursing facility and the financial and medical traps waiting for you there. If you don't know those, everything we covered today only protects half the journey. Subscribe so you don't miss it. It matters more than you think.